So, good afternoon, everyone. So, I think, the last batswoman in this test series that has had lots of academics over the last 4 years. And I'm happy to see a lot of people still interested and sitting in the hall. So, the task assigned to me today is diabetes remission in the real world. And this is something towards which all of us are working, because all of us, when we see our patients with diabetes, this is one thing that can really change life for them. So, my slides are not moving. Okay. Of course, no disclosures for this talk. Before I talk about the real world remission, let me just clarify a few things, because this is something all our patients come to us with social media saying diabetes can be reversed. So, this is where we really need to understand and make it clear to them that reversal means complete restoration to good health. That means it's a complete U turn, it's been cured, and it's never going to come back. However, remission is defined as abatement or disappearance of the signs and symptoms of a disease. So, for a chronic illness like type 2 diabetes, it may be more accurate to call it remission rather than a reversal. And of course, type 1 diabetes, of course, cannot be reversed at all. So, when we talk of remission of diabetes, let me put things in perspective. There's something called partial remission, which means achieving an HbA1c of less than 6.5, which is the cutoff for type 2 diabetes, for at least 1 year in the absence of active pharmacological therapy or ongoing anti-diabetic procedures. So that's what we call partial remission. However, complete remission is another entity which says that the glucose levels are normalized to an A1C value of less than 6% and fasting glucose less than 5.6 millimoles for at least 1 year while not on any glucose lowering drugs. That's complete remission. And then you have prolonged remission when your patient is able to retain normal glucose values for at least 5 years without any medications to lower blood glucose. Now, facts are, we've always been talking about type 2 diabetes being a lifelong disorder which is irreversible, and there's progressive decline in beta cell function. However, bariatric surgery has shown that there is restoration to normal glucose levels in patients with type 2 diabetes even within days before all the other metabolic changes come in. So, the important question is, can we reverse diabetes? What are the mechanisms that can probably lead to this effect? Of course, theories are changes in the gut hormones or profound reduction in calorie intake. So the definition for remission has been refined, it has been revised, discussed, debated in many forums. Type 2 diabetes remission is now understood to be a healthy clinical state where HbA1c stays below a targeted level and is maintained for at least 6 months with or without continued use of lifestyle modification and or metformin. And an important part is without concomitant complications or interventions that may cause hypoglycemia. Therefore, when we talk of metabolic remission, we talk of pharmacological remission and we talk of biochemical remission. Metabolic remission means reversal of insulin resistance or the secretory defect, which are the hallmarks of type 2 diabetes. Pharmacological remission means there is absence for need of any form of drug therapy to achieve this kind of levels. And biochemical remission may be complete remission or clinically significant partial remission. Complete means A1C stays below the diagnostic threshold for diabetes, and clinically significant or partial means HbA1c that is below the target set for a particular individual. So when we talk of the natural history, we say diabetes is inevitably a progressive disease requiring a number of OADs, requiring eventually insulin therapy. So this inexorable deterioration in control has been interpreted to mean that the condition is treatable but not curable. So if you look at the most famous UKPDS slide, which compares the intensive arm versus the conventional arm, the A1C comes down, but over the years it starts climbing up. What we understand is this climb up happens because of the progressive beta cell loss that happens both in the intensive group as well as in the conventional group. So when we talk of the feasibility of maybe diabetes prevention, we know there's a long period of pre-diabetes or glucose intolerance that precedes development of diabetes, and therefore screening tests that can identify an individual at this stage can help in some important interventions that can address at least the modifiable risk factors in terms of obesity, body fat distribution, physical activity, and raised glucose. So, of course, when it comes to interventions that may reduce progression from pre-diabetes to diabetes, you have therapeutic lifestyle management, which is the cornerstone. And of course, no pharmacological agents have been indicated. However, metformin is recommended by the ADA as a primary medication in pre-diabetes because of its potential to delay progression to type 2 diabetes. So these are a number of diabetes prevention trials that we all know about. So I won't go into the details. You can see all the Darking study, DPS, DPP, tripod, stop NIDDM with different pharmacological agents where remission was attempted. The lesson that we've learned from all these trials is even modest weight loss can lead to dramatic reduction in the risk of developing type 2 diabetes, because eventually it is this vicious cycle of insulin and calorie intake that your patient gets trapped into. So on the one side, there is metabolic dysfunction and insulin resistance leading to a state of hyperinsulinemia, which increases the hunger, and therefore there is an increased caloric intake. And this chronic caloric intake further aggravates the metabolic dysfunction, the insulin resistance, putting the patient in this vicious cycle where he gets trapped and cannot come out. So the famous twin cycle hypothesis, with the liver and the pancreas having their role, we know that chronic calorie excess will lead to accumulation of liver fat, which eventually will spill over into the pancreas, thereby causing a metabolic inhibition after meals and onset of hyperglycemia. So is reversal of type 2 diabetes actually a reality? Well, bariatric surgery says yes, your patients do go into normal glucose levels within days of bariatric surgery before substantial weight loss has actually come in. And about a quarter century ago, Porres et al. Demonstrated that glucose levels normalized in obese patients with type 2 diabetes who underwent bariatric surgery, and 10 years later also almost 90% of them remained free of diabetes. However, there are theories on how this can happen. Of course, it requires an acute massive reduction in calorie intake. So the sudden reversal of traffic of fat in the fat stores leads to a major change in the intracellular concentration of fat metabolites. So the hypocaloric condition, wherein fat is mobilized first from the liver and the other ectopic sites rather than from visceral or subcutaneous fat stores, may hold the key. So the important part is this hypothesis correct? Because if the rapid change in metabolism following bariatric surgery is a consequence of the sudden change in calorie balance, then defects in both insulin secretion and hepatic insulin sensitivity should be correctable by changes in diet alone. So when I talked about the twin cycle, where I said excess fat intake deposits in the liver, and once the liver is full, it spills over into the pancreas. So there's resistance at the liver, there's resistance at the level of fatty pancreas, which eventually sets the patient into this vicious cycle. We may reverse the twin cycle effectively to improve the beta cell function if negative calorie balance is achieved, which means liver fat comes down, it improves the insulin action, normalizing the overnight blood glucose levels, and the pancreas fat is reduced, by thereby normalizing the insulin response to eating. So both the fasting and the postprandials can be controlled. So this twin cycle hypothesis was tested by a number of studies. So the number one is hepatic insulin resistance and beta cell dysfunction reversible by reducing intra-organ fat content? I showed you the liver fat and the pancreas fat are the two targets that you need to see, and this is where the counterpoint study came in, and I'll come to this in a little while. And then the next question was, is the return to normal metabolism durable after return to an isocaloric diet? This is what was addressed by the counterbalance study. So the answer was yes. And then the next question was, can this be translated into routine management of type 2 diabetes in primary care? And this is where the direct study comes in. And then there are certain questions answered in terms of evidence for pancreas fat being the cause of beta cell dysfunction. So if you can remove the fat from pancreas, can the beta cell dysfunction be kind of improved? Well, there are beta cell studies, and bariatric surgery is a great example of improvement in beta cell function as well. So counterpoint study, to be brief, was basically looking at reversal of type 2 diabetes, normalization of beta cell function in association with reduction in the pancreas and the liver fat. So basically 11 people, a very small study, 11 people with type 2 diabetes, You can see BMIs were 33.6, 9 were males, 2 were females. They were studied, they were put on a very low calorie diet, 600 calories per day, and they were studied before and after this particular calorie regime after 1 week, 4 weeks, and 8 weeks. And what it showed was the VLCD not only reduced the fasting plasma glucose because all hypoglycemic agents were stopped, and you can see the fasting plasma glucose from 9.2 coming down to 5.6, and this was associated with rapid fall in liver fat, rapid normalization of liver insulin sensitivity, and a gradual fall in pancreas fat with a gradual return of the first phase insulin response, which takes the first hit when your patient gets diabetes. So the counterpoint study showed the effect of a very low calorie diet in terms of reduction in the hepatic triglyceride content. Hepatic insulin sensitivity index improved, so the liver resistance is taken care of. Pancreatic triglyceride, so the pancreatic fat is reduced, and of course you can see a restoration of the first phase insulin response. So clearly you can see here that patients with type 2 diabetes up to 4 years duration regained their absolute normal fasting glucose levels within 7 days of commencing this very low calorie diet, despite stopping metformin on day 1 of the diet. Now, counterbalance study. This was patients with type 2. Duration was about 0.5 to 23 years, followed on a VLCD for 8 weeks. All oral agents or insulin therapies at baseline were stopped. And then there was a stepped return to isocaloric diet. A structured individualized program of weight maintenance was provided. So the first study showed you put your patient on VLCD and you see a restoration of function. Now this is about maintaining them. When you introduce them to an isocaloric diet back in a stepwise manner along with an individualized program of weight maintenance, is it retained? Yes, you can see it here. Fasting plasma glucose, HbA1c and weight all coming down, and you can clearly see all across the spectrum of HbA1cs, you can clearly see 10 weeks and 6 months, the first phase insulin response is still normalized. Now moving on to the direct study. This was an open label cluster randomized trial at 49 primary care units in Scotland and England. This was basically, intervention was a weight management program versus the best practice care of guideline, which was the control arm. This was again patients with type 2 diabetes within 6 years of duration, BMIs between 27 to 45. These were patients not on insulin, they were on oral drugs, and the intervention was they withdrew their anti-diabetic and anti-hypertensive drugs, and there was total meal replacement here. So about 800 plus per day formula diet for 3 to 5 months was given to these patients, and as you can see here in the intervention group, you can clearly see weight loss of 15 kilograms or more was achieved in 24% of the participants. Again, you can see if you look at the quantum of weight loss and the proportion of patients who achieved remission, you can see less than 5 kilograms weight loss, 7% in the intervention arm were able to achieve. And as the weight loss quantum increased, so 5 to 10 kilograms, 10 to 15 and more than 15, you can see diabetes remission happening in 46% participants in the intervention group and even 4% even in the control group. So any amount of weight loss definitely is beneficial, and at 12 months almost half of the participants were able to achieve remission to a non-diabetic state, and they were off anti-diabetic agents. Remission is a practical target. So you can see this was maintained over the period of time over 1 year as well as 2 years. And who are the patients who achieved a durable remission? These were patients who had a greater weight loss from baseline, greater weight loss that was maintained over 1 year and 2 years. It did not vary with the baseline BMI of these patients. And of course, slightly people who fared better were people who were in the older age group and the male sex. So the conclusions were very clearly that yes, if your patient is able to achieve a significant weight loss, maybe diabetes can go into remission. Maintaining weight loss, of course, is challenging, and your patient needs a lifelong weight maintenance regime. Early remission should therefore be a primary target, and this is the beta cell restoration that I talked to you. Patients' beta cell function is restored. Now, pharmacological assisted remission means you use drugs for short term and expect long term remission, especially at a pathophysiological levels, and these are various studies where glucotoxicity and lipotoxicity basically were addressed with a combination of different agents. So this is one study on remission of type 2 diabetes with glargine, sitagliptin, metformin. This is another study. You can see here interventions with therapeutic agents. So clearly, whatever route you take, if your patient is able to achieve a significant weight loss, maybe that is a very important driver driver where your patient can achieve a successful remission. This is a number of studies you can see here. So clearly, does it make sense to use the phrase drug sensitive remission or partial remission for these patients? Because the moment they put on weight, the remission goes away and they're back. So I think this is very important. So my concluding slide, should we really talk about remission and promise the golden remission to all our patients? Well, yes, you can encourage your patient, because this is something that is going to put him on a trajectory for weight loss, weight maintenance, healthier lifestyle, healthier eating habits and exercise. But after successful dieting or surgery, your patient should not have the feeling that he's been cured of the disease. That is very, very important. So the minute they let their weight or lifestyle control go, the disease will return. So rather than talking about remission, it's important we focus on the importance of maintaining a healthy lifestyle, perhaps even if it needs a certain pharmaceutical drugs to combat obesity, and maintain appropriate glucose levels, for which the patient is rewarded with significantly improved prognosis with respect to both the debilitating complications and mortality associated with type 2 diabetes. So yes, in the real world, it's important that you encourage your patient to lose weight, to attempt a remission, but staying in remission is a very uphill journey wherein your patient needs to be motivated lifelong for a healthier lifestyle and eating habits if they want to stay in remission. Because in the real world it is possible, but maintaining it is something which is a huge challenge that you need to partner with your patient and handhold him to stay in remission for as long as possible. Thank you so much.